Afternoon and a very warm welcome to NITRD NTF Collaborative Difficult to Treat TB Clinic. I'm Dr. Neeta Singla. I'm Nodal Officer of DRTB Center at NITRD and Nodal Officer for ECHO Program. Very Happy New Year first. Today I'm joined by my team. I have Dr. Rupak Singla, who's head of the department TB and Chest in our institute and is also the inventor for this program. And I have Dr. Amitesh Gupta with me, who's Senior Medical Officer and will be supporting me in running this program, along with team from ECHO India. Privileged to have DDG TB, Dr. Rajendra P. Joshi with us, and he will be sharing his thoughts with us. Sir, a very warm welcome. A very warm welcome to all the senior faculty who's here, all the state TB officers, directors of NIRT Chennai, directors of STDCs, district TB officers, faculty from medical college, and all participants. For today's clinic, the team, the ECHO team and the NITRD team are working remotely due to COVID situation. So there could be some technical hitch and maybe a few seconds to, so please bear with us. Now I request Director Dr. Devan sir to give his introductory remarks.
Thank you, Dr. Neeta. Thank you so much. Good afternoon, everybody. And my naman to all my seniors, Dr. Rajendra Prasad, Dr. Jay Kishan, and so many others I am seeing here. Thank you so much for joining and encouraging the TB Clinic, which is one of the flagship programs of NITRD in our bit of contributing towards knowledge of tuberculosis, difficult to treat TB and DRTB, and is being very enthusiastically attended by people across the country. I see that, and generally I can say on an average 600 to 700 is the average, in which every session is attended by at least 600 to 700 participants. It's a very good participation for any program. And as I have been told by Dr. Neeta, today will be addressed by Dr. Rajendra Joshi. Because recently, but not so recent now, 1 or 2 or 3 months back, he has taken over the charge as Deputy Director Tuberculosis. And Dr. Joshi sir, the last week I was asked by University HMR University to talk about NTB program, and they introduced me as the government spokesperson. So I said, no, the government spokesperson is Dr. Rajendra P. Joshi. I am one of the national institutes and support them. Will be interesting to hear how.
Of us, sir.
Of course,
you are part of us.
You are part of us. But your views will be very interesting to hear in these times. And COVID has affected our TB control programs quite severely, and yet the resolve to achieve the goal by 2025 still exists. And this kind of the program which is going on, and I'm also very happy to see that my younger colleague Dr. Anuj will be speaking today. He has been there, and I wrote from medical postgraduate student, the head of the department and leading an institution which is going to very soon become a center of excellence care. I'm very happy to be a part of this program. Thank you so much, Dr. Neeta, for asking me to give the introductory comments. You please hear from me and carry the program forward. Thank you.
Thank you, sir. Thanks a lot. I would now like to introduce our DDG, sir, Dr. Rajendra P. Joshi. Sir is currently the DDG at the Ministry of Health. He has a very vast experience in the field of health and public health. He has been associated with Central Health Services since 1987. He was awarded WHO Fellowship in 2000-2005. He has experience of working in infectious diseases epidemics like swine flu, Ebola virus, and he has published several articles on health subjects in Kannada and English. He has given several talks on multimedia and live interviews on health subjects on All India Radio and Doordarshan for many. Welcome you, sir, and over to you for your thoughts.
Thank you, madam, for those kind words. Good afternoon, everybody, and wishing you all a very happy, healthy new year. I see many familiar faces here. Very good to interact with them again. On behalf of CTD, I welcome all the participants for this very, very important and useful what we call a workshop where we learn from each other. At the outset, I would like to NITRD, Dr. Diwan sir, Dr. Rupak Singla sir, madam, and all the team successfully running this national difficult to treat clinic with the collaboration with CTD and NTF for more than 1 year. And like Diwan sir was saying, the patient is very good, which is really encouraging. As we treat TB, as we go towards the goal of eliminating TB, it is also important that we support our colleagues in the periphery, where we face challenges as a clinician when there is something which is a bit difficult to treat. It is not responding or I have got doubts. So CTD started the concept of state level difficult to treat clinics, and I'm very happy to share that 26 states and union territories have started the state level difficult to treat TB clinics, and from there we escalate to this forum. It is a national difficult to treat clinic, and thankful to the chair of NTF, Dr. Ashok Bharadwaj sir, for supporting this to NIRD, and of course my team is always there to help you all. I am very thankful to Dr. Anuj Bhatnagar sir for taking the session as a national level consultant for this, and I'm sure all of us will learn from his vast experience. So what I request is all the states, you please schedule at least monthly, if more, webinar to discuss the selected cases for wider knowledge, because DRTB is not only drug resistant, but it is also D also stands for bit difficult to manage. So the experience of the seniors and experts actually helps the build the confidence in the periphery. So I request all to actively do it. And whenever opportunity arises, you can also do it physically, but at least webinars can definitely be done monthly level. So I don't want to take much time in this important topic. I just want to hear the presentation by Trivedi and the discussion on that. So I am very happy to be part of this, and thank you all for following me. And on behalf of the team, I assure you CTD will give full support to this very, very important workshop. Thank you all.
Thank you, sir. Thanks a lot. And now we have a presentation from Central TB Division regarding the comprehensive clinical management. And Sandeep Chauhan, who has 10 years working with the program, he's the national consultant for drug resistant TB and is working with WHO technical support, and is currently at Central TB Division for last almost 2 years now. And we have lead discussant Dr. Ravindra Kumar, specialist at Central TB Division, and he also has a very wide experience of TB in ESI hospitals and the program, and is currently at Central TB Division. I request Dr. Sandeep Chauhan to give his presentation.
Thank you, madam. Introduction. Am I audible?
Yes, sir. You are loud and clear. Thank you.
Thank you, madam, for the introduction. I'm presenting on behalf of Dr. Ravindra Kumar. He's busy in another meeting, so he will join between participate in query solving. Good morning, all. DDG sir, Dr. Diwan sir, Dr. Rajendra Singla sir, and all. I'm sharing my screen. Hope my screen is visible.
Yes, it is visible.
Is it in presentation mode or it's in slideshow?
Presentation mode. It is fine.
Okay, fine, ma'am. Thank you, ma'am. So I'm presenting a comprehensive clinical management protocol recently developed by Central TB Division with the support from experts committee, which consists of clinicians, public health experts, and program officers. And this was endorsed by the program. The idea behind the development of this clinical management protocol is to have a comprehensive protocol available at all the OPDs, maybe public health sector OPDs, private sector OPDs, so that the clinicians or the treating physician have the comprehensive information about the existing guideline, the program guideline. And they so earlier times, my seniors must be aware about this. We used to have a comprehensive algorithm available few years back, and every OPD is having this type of algorithm pasted at their OPDs in front of clinicians, so that they can treat the patient according to the program guidelines. So this is the revised one guideline algorithm that that covers the entire spectrum of TB, which starting from TB infection to DSTB to drug-resistant TB. So I will go through the algorithm one by one through every boxes. So the box 1 explains about the integrated algorithm for TB disease. So starting with the presumptive TB, once the presumptive TB patient is identified, the NAT is the preferred test for diagnosis as per the availability in the states. Simultaneously, microscopy plus chest X-ray and other tests are there to detect the TB. Accordingly, then the chest X-ray, if the chest X-ray is suggestive of TB, we can start the patient on DSTB regimen. And if the chest X-ray is negative, we should have options to go for other test. Sorry. In NAT, if we find MTB detected and rifampicin sensitive, DSTB regimen is the preferred choice, and if the rifampicin is resistant, the preferred choice of regimen will be decided based on the DST of the patient on first line LPA, second line LPA, and liquid culture DST. In case of rifampicin sensitive but isoniazid is resistant, we can start the regimen on H monopoly. So this is the algorithm for DSTB as well as DRTB. And on the right side, we can see the algorithm for TB infection. So in TB infection, in the high risk groups, the details of high risk groups and other details are mentioned in the footnote. So the high risk groups screen for 4 symptoms, and if they are showing any signs of active TB, then they will be referred to the left side of the algorithm. And if the patient is not having any symptoms of TB, the patient will further go to the TPT algorithm, TB preventive treatment algorithm, and accordingly will be started on TB preventive treatment. So this is the box 1, which consists of integrated algorithm, which consists of TB infection, DSTB, and DRTB, everything in one algorithm. Then the box 2 consists the public health action to be initiated at various levels. So the public health actions like patient home visit, counseling of patient and their family members, treatment adherence and follow-up, contact tracing, investigations, and subsequently initiation of TB preventive treatment, health counseling and testing, random blood sugar testing, drug susceptibility testing, linking with available social welfare schemes and other support schemes. So these are the public health actions need to be initiated for each and every notified patients. So the here we have listed the mandatory actions to be initiated at health facility level on the left side, and on the right side the actions to be initiated at community level. So the list of actions to be initiated at health facility levels consist of counseling of the patient and family members on TB infection, diagnosis of TB, contact tracing, and the TPT, importance of TPT, the importance of treatment and its completion, adherence, Nikshay Poshan Yojana, and these are the points we need to be taken in consideration while counseling the patient. Then comorbidity screening at the facility level, risk assessment for TB patients for differentiated TB care. So this will cover in next subsequent slides. Initiate the patient on appropriate regimen. So that is also will come in subsequent slides. The collection of bank details for Nikshay Poshan Yojana and follow up during treatment. So these are the actions need to be initiated at health facility level. On the right side, the mandatory actions to be initiated at community level. The home visit by the health worker within the 3 days of diagnosis. Counseling of patient and family members by the visiting staff on the following points. The bank details collection for Nikshay Poshan Yojana, geotagging of patients in Nikshay. This is also an important component of home visit to tag the patient on Nikshay. Then contact investigations and the ruling out TB infection in the contacts, and if there are any eligible contacts, they should be initiated on TPT. So this is the box 2. Box 3 explains it gives the details on when to hospitalize the patient or when to consult a specialist as per the technical guidance for comprehensive package for differentiated TB care in India. So this is a document available on our website. The gist of this is when a patient is having BMI less than 14 kilogram per meter square, BMI less than BMI 14 to 15.9 plus, patient is having bilateral pedal edema or inability to stand without support, severe anemia with or without heart failure, unstable vital signs, complications of pulmonary TB, complications of extrapulmonary TB, complications of anti-TB drugs like hepatotoxicity or seizures, patients with comorbidities, and sometimes the treating physicians feels the patient's admission is required. So these are some of the criteria where patients require expert consultation or the admission to the hospital. So this is also listed in the algorithm. Then the various regimens available for various types of disease. Like the regimen for DSTB is 2 months of HRZE plus 4 months of HRE, with the criteria for extension. In case of extrapulmonary, we need to extend treatment for further more than 6 months. In H monopoly, we have a 4-drug regimen for 6 months and a criteria for extension of treatment. For drug-resistant TB in MDR, RR-TB, or pre-XDR or XDR-TB, we have shorter regimen, shorter oral regimen, shorter injectable regimen, and longer oral regimen. So the shorter oral regimen will be given for the plain MDR, RR-TB patients without any other drug resistance. The regimen will be mentioned in the algorithm with the criteria for extension. A shorter injectable containing regimen is also there, but it will be phased out by April 2022. So this regimen will not be available beyond April this year. The longer oral regimen, MDR, XDR, and plus a PXDR patients given this regimen. This is a 5-drug regimen with the criteria for extension mentioned in the box. For TB infection, we have 4 regimens available. 6H for daily for 6 months, 6 months of isoniazid, 3HP 3 months weekly isoniazid and rifampicin, 12 dosages, 6 months of levofloxacin, which is given to the context of MDR RRTB patients with FQ susceptible index patients, and 4 months of rifampicin for the context of isoniazid monoresistant with rifampicin susceptible index patient. So these are the various regimens available in the program and the extension criteria. The box 5 explains the various follow-up schedule of various regimens. For drug sensitive TB, we have monthly clinical follow plus end of IP and end of treatment smear testing. For and plus any other test required as per the requirement. H monopoly, we have clinical monthly follow-up, followed by smear for monthly from 3rd month onward till the completion of treatment, and culture at the end of 3 month end of treatment, and other investigations as per requirement. For shorter regimen, we have a clinical follow-up monthly in IP, quarterly in CP, and smear and culture at the 3rd month onward monthly. And culture 3rd month at 3rd month, 6 months, and at the end of treatment, and other investigations as per requirements. For longer oral regimen, monthly clinical follow-up up to 6 months, and in the subsequently that will be quarterly. In the longer regimen, monthly culture will be done from 3rd month onward till the completion of 6 months, or if the drug is treatment is extended up to 7th or 8th month, it will be done up to that, and subsequently quarterly from 6, 7, or 8 months onwards, and other investigations as per indications. And there will be post-treatment follow-up, long-term follow-up, post-treatment 6 monthly screening of every patient, followed by testing if the patient is symptomatic. So this box 5. Now the box 6. What are the mechanisms available in the program which connects the patients or citizens with the program? So to start with, for notification, the program, we have a provision of incentive for private providers for a notification, 500 rupees, and 500 rupees on declaring the outcome of the patient. Then the credentials of NICSHE and NICSHE logins are available for in an Android app, so that private practitioners can monitor their patients. eSanjeevani is a platform available, which is a web-based comprehensive telemedicine solution where any patients can have their problem solved through telemedicine. For adherence, the program having ICT-based adherence systems apart from the conventional treatment supporter mechanism. 99 dots and MOM and video observed treatment. So these are the mechanisms available for monitoring the adherence. For patient support under program, we have NICSHE Poshan Yojana, 500 rupees per month to all the TB patients for the entire duration of treatment. This we all know. The travel support is given to the TB at the rate of 750 rupees for the in the tribal areas. Treatment supporter incentive is for 1,000 rupees for DSTB patients and 5,000 rupees for DRTB patients. Treatment supporter. The TB Arogya Sathi application is there for the informations on TB, symptoms of TB, side effects, health facilities available nearby the patient, BMI assessment, nutritional advice, social support. So this all things are available on TB Arogya Sathi. It is available on Play Store, and you can download it scanning this QR code available on this in this this chart. So apart from this, we have NICSHE Sampark toll-free call center. So these are the all information given on this system. Apart from this emergency phone system, dialing 108 can be available for in case of any emergency, and the program website is available to download all this information and the documents. Apart from this, in this chart, we have mentioned the selected definitions of the terminologies that has come in the document, and these are the important definitions for any medical officer, and the list of abbreviations mentioned. So finally, if we see the protocol looks like this, the one chart covers everything available. This is the latest information available with the program. and it is designed in 2 dimensions. One is to 1 dimension, and another one is 3 is to 4 dimension. So as per the availability of space at the facility, it can be printed and pasted in the website. The preferable will be 3x4 or 2x3 as per the availability of space, but it can be printed on, and even it can be put on the desk also. So that's all from my side. This is the comprehensive algorithm for every health facility. It should reach to each and every clinician who is treating TB patient in the country, and it's a very handy. It's available on even on circulated on WhatsApp groups, various WhatsApp groups. So that's all from my side. Thank you.
Thank you, Dr. It was a very clear presentation. And we have Dr. Ravindra Kumar with us, who's looking after at the Central TB Division. Over to you, Dr. Ravindra.
I have to check. I think
Sir is there.
another-
Dr. Ravindra is there. I think he's muted. Yeah. Thank you.
Can anyone confirm I'm
Yes, sir,
audible?
yes, you are audible.
Okay. Okay. Thank you, all the participants, Dr. Devan, Dr. Devan, Dr. Rajendra Prasad sir, Dr. Bhardwaj sir, for conducting these important clinical meetings. The main purpose of developing a comprehensive clinical protocol is that because we have already have different kind of trainings for drug sensitive TB, DRTB, and TPT under the program division. And many of our clinicians are trained in these different protocol trainings. But the problem lies with when it comes to our clinical management. So we have developed this protocol, comprehensive protocol that is easily available to the clinicians in their offices, in their clinics, and easily displayed in clinics, so that it is easily available to the clinician as well as PZs, as well as medical doctors who are not trained in these trainings, but these ready to use comprehensive protocol may direct and give insight what to do next. If patient come with this, suppose we have a sputum positive patient, patient with some investigations came to involve these patient in our national program. As you know, we have the best treatment for the drug resistant TB, and this is only available through our national programs. So once these patients are engaged with national programs, so they are provided with the best care in the form of bedaquiline or delaminetant drugs. So I may request all the clinicians who have joined, as well as the head of departments in different clinical setup or clinical institute, please disseminate this clinical protocol to your institutes, so that this is available in all your OPTDs or as a desktop, as a whatever you can be disseminate in your clinical groups, so that the people, your clinician should have how to engage with the program, and what is the care cascade in our national program. These are my comments, and
Thank you, sir. I would now ask Dr. Amitesh if there are any questions which should be now. You can take
Yes, ma'am. There are certain questions in the chat box. I will take them one by one. Dr. Ravinder, many of our participants want to know that from where can these slides and can you tell in that where?
actually we are in our website, we are hosting these slides in our website. Our website is under maintenance. In 1 week time, these are available or downloaded from our website. We are going to share these PPTs and other printing, even data related to how it can be printed. So these files may be shared with our NTF chairs and other state TB officials, and even the medical colleges as well as our teaching institutions. So it is easily available in our website as well as disseminated in all our related groups for the further dissemination.
Okay, right, sir. Thank you. Sir, there is one more question by Dr. Anand. Dr. Anand, he wants to ask that what is the duration of 1 month in DRTB, whether it is 28 days or 30 days? And what about in prophylaxis, whether it is same?
It is 1 month, 30 calendar 1 month, not 28 days.
30 days. Right, sir. Ma'am, there are a few more questions. I think we can take them after the case presentation. We can move to the case presentation, sir.
Thank you, Dr. Amitesh, and thank you, Dr. Sandeep and Dr. Ravinder. Thanks a lot. And now we move over to the next section, that is our case presentation. Before I move to case presentation, I would like to inform that today we are joined by 17 states. We have representation from 17 states. We have STOs and STDC from 15 states who have joined us. That is Kashmir, Punjab, UP, Jharkhand, Himachal, Andhra, then Maharashtra, Delhi, Gujarat, Rajasthan, Meghalaya, Mizoram, Nagaland. And we have maximum representation from Meghalaya and Uttar Pradesh today. So thank you for joining us. And now we move over to the case. The case is from Trivandrum today, and it is going to be presented by Dr. Shikha from Nodal DRTB Center, Trivandrum. And the lead discussant will be Dr. Sanjeev Nair. Dr. Sanjeev Nair is Associate Professor in GMC Thrissur, and he is also the Chairman State Task Force in the Medical College in Kerala. And he is also the member of National DRTB Committee, Guideline Writing Committee. And we have the national expert for the day today, that is Dr. Anuj Bhatnagar. He is head of the department at RBI Delhi, and he has more than 26 years as a clinician treating DRTB. He also has a key role in national expert group for DRTB. So over to Dr. Shikha for case presentation.
Thank you, ma'am. Good morning, ma'am. I'll be sharing my screen now.
Yeah, sure.
Good morning, all. I'm Dr. Shikha KC, respiratory medicine resident from King's Hill, Trivandrum, Kerala. Ma'am, is my screen visible, ma'am?
Yes, we can see your screen.
I'm presenting a clinical case of drug-resistant TB in a medical student. Presenting the case of a 28-year-old lady who's a doctor, a postgraduate resident studying in a different state with no known comorbidities, who presented to us in October of 2021. She was a primary contact of a COVID-positive patient and herself tested COVID RT-PCR positive on 27th of September 2021. She had a symptomatic COVID infection and tested COVID antigen negative on 5th of October, that is, over a week later. Since then, she had high-grade fever. She repeated her COVID RT-PCR on the next day, which was reported negative. And she presented to us on the 4th week of fever, and before reaching us was started on oral methylprednisolone 16 milligram for a total of 2 weeks. On presenting to us, she had persistent high-grade fever and occasional dry cough. It was not associated with breathlessness, chest pain, or hemoptysis. There was no history of loss of weight or loss of appetite, and no history of any prior respiratory illnesses. And she had no history of tuberculosis. On examination, general examination was unremarkable except for palpable lymphadenopathy in the cervical region, level 2 and level 4 group of lymph nodes, and right axillary region central group of lymph nodes. Her vitals and system examination were within normal limits. Investigations done elsewhere included computed tomography of chest, done twice, first on 28th of September and repeated on 12th of October, both of which showed small nodular soft tissue density opacity in posterior segment of right upper lobe located peripherally. Her serum ferritin, interleukin-6 and D-dimer levels done outside were within normal limits, and tuberculin skin test showed no induration. Blood investigations repeated here were within normal limits, and her connective tissue and vasculitic workup were also normal. On further evaluation, ultrasonography of neck revealed right anterior cervical suppurative lymphadenitis, which is followed by excisional biopsy of right cervical lymph node, in which smear for AFB and MTB gene expert were negative. Histopathological examination of the biopsy sample revealed necrotizing lymphadenitis with lympho and erythrophagocytosis, and Ziehl-Nielsen stain was negative for AFB, PAS negative for fungal organisms, and the biopsy was commented as possible Kikuchi disease. However, her viral workup including EBV IgM and CMV PCR were negative. The patient continued to have fever spikes and headache during these spikes, following which MRI brain was done, which revealed no significant abnormality with no abnormal parenchymal or meningeal enhancement. Neurologists had suggested puncture and CSF study, which was deferred then, as the patient at that point was not willing for the same. This is followed by an FPG whole body PET CT scan, which revealed metabolically active bilateral cervical, mediastinal, right axillary, retropectoral, and mesenteric lymph nodes, and mildly metabolic subpleural nodule in the posterior segment of right upper lobe, and metabolically splenomegaly. This is the final image of the PET CT scan, in which you can see the metabolically active cervical, mediastinal, as well as uptake in spleen. The differential diagnosis considered at this point, where first was tuberculosis, presented with right upper lobe lesion with cervical lymphadenopathy and a possible history of con, because she is a postgraduate medical resident. The second was Kikuchi disease. The second was Kikuchi disease, as was reported in the biopsy sample, which in her case could have been precipitated by a viral infection, which is possibly COVID. And the third was lymphoma. She was given the option to wait for IHC of the biopsy sample or to proceed with mediastinoscopy and biopsy. We proceeded with mediastinoscopy and mediastinal lymph node biopsy, which was done under CTVA surgeon on 4th of September 2021, in which histopathological examination again revealed epithelial granuloma with central necrosis, in which Ziehl-Nielsen stain showed few acid-fast bacilli, and MTB gene was done, in which MTB was detected low and rifampicin resistance detected. Now, with the diagnosis of multi-drug resistant tuberculosis, first line and second line LPA were sent, and she was initiated on longer MDR regimen, which includes aquilin, linezolid, levofloxacin, cycloserine, and clofazimine. Reports came as follows. The first line LPA showed rifampicin resistance detected with CAT-G mutation resistance detected, and second line LPA showed levofloxacin and moxifloxacin resistance detected. This is the picture of the line probe assay report. The further treatment and discussion will be carried out by National Difficult to Treat Clinic expert, Dr. Sanjeev Nair, sir. Thank you for your patient listening, and I'm humbled to have presented on such an honored platform. Thank you.
Thank you, Dr. Shikha. That was very clearly presented case. Over to Dr. Sanjeev Nair, sir. Those who have missed the case, just in very short, this is a young female doctor, known case of who had COVID. She was a known case of COVID, but she became negative weeks time and presented with fever of 3 to 4 weeks, and she had cervical and axillary lymphadenopathy, and lymph node biopsy features suggest tuberculosis. Over to you, Sanjeev, sir.
Thank you.
Yes, sir, you are clear.
And the screen in slideshow mode is also visible.
We can see your screen also.
So, good afternoon, everybody. Again, thank you for this opportunity from Kerala for this opportunity to present this interesting case. I would start by congratulating Dr. Shikha for the excellent presentation that she made, very crisp, and within time she finished her presentation. So with the presentation, you could understand the difficulties in a diagnosis of a case like this. Of course, I'm not going to discuss that part of it, but you should see the effort that the team in KIMS Hospital Trivandrum had put in for the diagnosis of this patient, who also happens to be a young doctor. So they were doubly concerned about the patient and did a thorough evaluation. My friend, Dr. Arjun and Amir were in charge of this patient, and they thoroughly worked up the case, and you saw all the investigation they have been done. So we should understand from the very beginning that if the patient had not gone such a detailed evaluation, you can see a lesion on the CT in the lung, you can see the cervical lymph nodes, but all of that turned out to be negative for TB. So finally, the diagnosis was clinched based on a mediastinoscopy, which many of us, even in the government sector, in the medical colleges, often struggle to get done. It's not that it's not possible, but often it's difficult to do. So at the end of the day, I mean, even without that, maybe we would have made a diagnosis of TB, clinically diagnosed TB would have been made, but we would not have made that diagnosis of drug-resistant TB as well as the pre-XDR, which we could make because the mediastinoscopy was done. But that is not part of what I'm going to discuss today. My discussion will be actually be limited to certain other aspects related to the program and to the difficult to treat clinic. So basically, my job for the day would be discussing on how we would design an optimal regime for this particular patient. We would also discuss briefly on how to manage the patient when the patient has an adverse drug reaction and how we modify the regime based on that. And finally, the most important part I feel of this discussion is how the private sector and the government sector can actually work together in making a success out of drug-resistant TB treatment, which often is lacking. And this is an excellent example of how it can be done. So this particular patient, this screen was shared by Dr. Shikha with you on the results that came in. In fact, after we reviewed the results again, we did discuss with the IRL team in Kerala that probably, this result could have been much more elaborate, and that part of it I'll just share with you after the further discussion with IRL team, what I got for you. So this particular patient, we further asked for the mutation analysis in addition to what was there in the NTP report that you saw. So in the mutation analysis, you can see that this particular patient had the wild type 8 for RPOB missing with a mutant probe 3, which appeared, which indicates that the patient has rifampicin resistance. And the patient also has a wild type 1 absent for CAT-G with a mutant probe 1 being present, which indicates that it's a high dose INH resistance. What you can see is that based on that, the interpretation which came in the previous slide of INH resistance and rifampicin resistance came about. But in addition, what information we need is that for the INHA locus, both the wild type probes are present and mutant probes have not appeared, which actually indicates that in this particular patient, if needed, ethionamide can be used in the regime. So this is something further that we got out of the IRL team. And the second part of it is the second line LPA. In the second line LPA, you can see that the for Guy-Ray, the wild type 3 is missing and the mutant probe 3B is present, which actually indicates that levo cannot be used in this patient, and also that high dose moxi cannot be used for this patient. So this is a very high dose quinolone resistance, which actually means that both levo and moxi would not be applicable for this patient. There is no second line injectable resistance. So if at all you want, you can actually use amikacin for this particular patient if needed. So based on that, we look at what other regimes are possible for this particular patient. So you just saw Dr. Sandeep presenting to us on what are the various regimes, the 4 regimes for drug-resistant TB. So these are the 4 regimes that he presented to us right now. And you can see that you have 4 different regimes which are possible if you have a drug resistance in your patient. Now, the first regime obviously is out because there is rifampicin resistance, and that is for people who have only INH resistance and no rifampicin resistance. So that regime is out. The next 2 regimes are shorter regimes, one of which, as Dr. Sandeep said, is being phased out. Those 2 regimes are also not applicable for this patient because this patient has fluoroquinolone resistance, which makes the patient ineligible for those 2 regimes. So all we are left with is the oral longer regime. So you have to go with that particular regime. And that regime has 6 months of bedaquiline followed and a total duration of 18 to 20 months of the other 4 drugs. But in this particular patient, even that regime as such is not possible because there is a fluoroquinolone resistance. So there is a levofloxacin resistance. So you cannot give this regime as such, and you have to substitute drugs in this particular regime. Now, when we start substituting, the first substitution, obviously the easiest substitution is to substitute levo with a high dose moxi, but high dose moxi cannot be used in this patient because our second line LPA suggests that this patient will not respond to high dose moxi as well. So now you have to go for further, substitution. We should remember that this patient started treatment at a time when our new MDR-TB module had not come out. So that came out last year in, March, and we did the national training and all that. But at the particular time when we started treatment for this patient, at that time we did have the national technical expert group available, based on which the module was being formed, but the new module was not out. So we were in a phase where change was occurring. So, replacement drugs as per the previous guideline, which was available at that particular time, was different. So the substitution pattern was different. And as per the new guideline that came in, the substitution pattern is different. So what we do now is we go with the new guideline. But at that particular time, there was a bit of confusion on what we should actually be following, whether the old guideline or the National Technical Expert Group recommendation. In any case, because of certain reasons, we had to go with that newer or incoming replacement sequence where delamanid is the first drug to substitute. So this particular patient, either we could have gone with the older guideline and substituted with amikacin, or a newer guideline and gone with delamanid. For particular reasons, which I'll be discussing later, we actually went with delamanid. So the patient was offered 6 months of midazolam and delamanid, along with the total duration of 18 to 20 months of linezolid, cycloserine, and clofazimine. So this was a regime that was decided by the state difficult to treat committee at the state level with concurrence, because this was the first time in Kerala that we were using midazolam and delamanid together, and we did not have enough confidence or experience in this particular thing. So we reached out to the National Difficult to Treat Clinic. Dr. Singla was giving us confidence as well as sharing his experience, having given such regimes to other patients, and based on his experience with close monitoring of QTC in this particular patient, we started this particular regime. Now, if you go with the current guideline, you can see that the current guideline replacement table, which I have projected in front of you, clearly says that in such a scenario where no fluoroquinolone, both levofloxacin and moxifloxacin cannot be used for your patient, then the substitution is actually using midazolam, linezolid, clofazimine, cycloserine, and delamanid, which is exactly what we did in this patient, and a second phase or the continuation phase of linezolid, clofazimine, cycloserine. So this was exactly what we decided. The only thing is at that particular point of time, this particular regime was not current. But now, if you go with the current guideline, exactly what is recommended was what was done for the patient. Of course, we were expecting that we were giving midazolam and delamanid together in this patient, and that we would have probably QTC problem, but that did not happen for this patient. The doctor herself gave us assurance that she will closely monitor her QTC. She would do ECGs regularly, and she learned herself how to do her own QTC. So she did not have that problem. And the problem that occurred was peripheral neuritis, which actually occurred a bit late in the intensive phase. So you can see that it's at the start of 5th month of treatment. She had already taken 5 months of treatment when this occurred. It was extremely severe for the patient. She was finding it difficult to walk. So we consulted with our neurology HOD, Dr. Thomas Ipe, who is a national expert, who's part of the Index TB guideline committee and all that. So he started some supportive drugs for peripheral neuropathy, and he also reduced the dose of linezolid to 300 for 2 weeks. But even after reducing for 300, her symptoms did not come down. Her peripheral neuritis remained severe. And then the state committee as well as the neurology team got together and decided that this patient, particularly because of the severe side effects, cannot continue linezolid. So at this point of time, at the end of 5 months of treatment, we took a decision to stop linezolid in this patient permanently. So now the problem occurs that your regime is like this, and it's in this particular regime, we have stopped a key drug, linezolid. So now you need to substitute that group A drug. Now the problem is that this intensive phase is almost over. So, it's 5 months of treatment is already over. So the next drug, if you remember the replacement sequence, the next drug to substitute here is amikacin. But amikacin should be substituted only during the intensive phase. So in the last part of treatment, during the continuation phase, you do not substitute with amikacin. So that substitution would not have had any meaning here. And because of that, because only 1 more month of intensive phase was to go, the committee felt that we have 4 effective drugs in the intensive phase, so let us not substitute for the intensive phase. But even having said that, the point is that even if you don't substitute at this point, if you look at the continuation phase now, you will have only 2 drugs left, and those are cycloserine and clofazimine, 2 group B drugs, and such a regime definitely is inadequate for the patient. So there, a substitution is definitely needed. So how do we substitute at this point of time because of an idea? So there are two options. If you go with the current guideline, which again was not really, the training and all was just going on at that time. If you go with that particular guideline, you are supposed to substitute that linezolid with pyrazinamide and ethionamide if you're substituting during the continuation phase. Of course, the same drugs could be given in the intensive phase as well when you substitute at 5 months. So that is one option that we have. And the second option, if you cannot give these two drugs, pyrazinamide, ethionamide, cannot be given to your patient, there is an option which is rarely used, which is given in the guideline, that you could continue bedaquiline for the entire duration of treatment, so that you have 3 effective drugs in the continuation phase as well. Now, this is a rare option which should be considered only if you cannot substitute with other group C drugs. Sorry, post-COVID cough. So in this particular patient, we had certain issues, that there was a minimal LFT derangement, and so we did not want to, substitute drugs and lead to further ADA. So in this particular patient, as a rare case, after extensive discussion and also getting a concurrence from the National Difficult to Treat Clinic, the State Difficult to Treat Clinic decided that we will be continuing bedaquiline for the entire duration of treatment for this particular patient. So this is once in a while you get a very rare situation where you give bedaquiline for the entire duration of treatment for a particular patient. It can be done only very rarely with concurrence from the National Difficult to Treat Clinic, where you actually have no option, because the replacement drugs like pyrazinamide, ethionamide, and PAs could not be used for this patient. In the continuation phase, you don't use the injectables, amikacin and the other injectables. So you have no option. The other substitution drug available is ethambutol, and we felt that one ethambutol would not be enough in this particular patient. So a rare situation where you gave bedaquiline and delamide in the beginning of the treatment, and also continued with bedaquiline during the entire treatment. So that was the peculiarity of this particular patient's treatment, which we want to discuss. The last bit of it, which I'll go through fast, is the private and public working together for a patient. Now, our national conference, many of you are pulmonologists in this group. The national conference comes every year, and there's always a heated debate on that private sector and the government cannot work together under NTEP. Guidelines cannot be followed, that the private sector is not being provided bedaquiline and delamide. It's a constant conflict that most of us see during our national conference. But this particular case shows to you that that is not the reality everywhere. So you have this particular patient who was diagnosed at the leading private hospital in Kerala, one of the leading tertiary care hospitals, with some of the best pulmonologists in the private sector in the state of Kerala. Dr. Arjun and Dr. Amir are very famous throughout the state and even at national level. They provided the best quality diagnosis and supportive care for this patient. So you can see that the kind of diagnostic evaluation that was done for this patient may not really be possible in some of the medical colleges. So that level of care was provided for the patient. The hospital itself, the private hospital, they themselves have their NAT, they have MGIT, so they are well equipped. But this hospital is aware, that consultant pulmonologists are aware that you need a first line LPA and second line LPA when you diagnose rifampicin resistance, and they know that is not available in the hospital, and there is no hesitation at all to send samples to the IRL for doing the first line, second line LPA, which was done immediately without any delay. And the moment they diagnosed MDR-TB with fluoroquinolone resistance, they immediately consulted the state PMDT committee and the state difficult to treat clinic on how to manage this particular. Not that they don't know how to do it. They are experts. Dr. Amir, Dr. Arjun are experts. They know what to do, but still they know that there is a way of managing patients through a committee, and they immediately referred the patient to the committee, and the young lady did come to our hospital for a discussion. So you can see this going to and fro. So, diagnosis at the private sector, going referred to the IRL, and then from the IRL again going to the PMDT committee. So it is going from government to private, private to government, and the whole thing is happening. The patient had a comfortable stay in the private hospital. She was not willing for admission at the government hospital. So she continued in the private hospital, where we actually initiated bedaquiline, delamide in the private hospital itself. And the cardiologist at the private hospital was actually monitoring the patient. So, when there is no issue of cost and the patient is able to afford the cost of a private hospital, and the doctors are willing to discuss with the program, there is no issue at all in bedaquiline delamide being provided in the private hospital itself. And you can see a majority of the work for this patient was done in the private sector, and a significant proportion of the work was done in the government sector. So both these sectors working together. So at the end of the day, while monitoring, following up the patient, the state TB cell was doing extremely good work with Dr. Deebu at the state TB cell monitoring the patient, even when she was transferred out to another state. The private doctors also remained in consultation with the patient, and she was consulting us at the state difficult to treat clinic. Dr. Anita Kumari and myself were also under the, we were all being consulted. So a team of doctors working as a team without any problem at all. And this patient was managed successfully. Now, why this success? How could this happen? So the most important thing here is there was no ego between the doctors. Nobody felt that I am superior or the other person is inferior. So everybody was working as a team. The private team did understand that quality assured diagnosis is important for this patient. So they immediately sent for the appropriate investigations to the IRL. There was no ego there that our hospital is better. Again, the private sector doctors who are experts in the field of TB did know that the best regimes are these, that bedaquiline, delamanid should be provided for this patient. And they decide best regime for the patient. And at the end of the day, all the doctors working for this particular patient place the interest of the patient above their own interest. So that is the key for the success for treatment of this particular patient. What happened to the patient? The patient tolerated all the drugs later, except for the peripheral neuritis, which led to linezolid being stopped. All cultures which could be done. You should understand that she was not having much of sputum. So cultures was not done throughout, but whenever cultures could be done, cultures was negative. She had a weight gain of 10 kilograms. She's totally asymptomatic now, and now you have a treatment success. Of course, we are patting the doctors each other on their back, but we should understand that this particular patient was a doctor who got MDR-TB as part of her work as a doctor. And I salute the patient for having taken drugs regularly, for having gone through the entire process without any complaint and having successfully managed herself and got successfully managed and cured of this particular disease. So salutes to that particular champion also at the end of the day. Thank you so much. I'm open for questions.
Thank you, sir. Thank you. It was very, very clearly explained. So before I invite Dr. Anuj Bhatnagar for his comment, do we take questions, or Dr. Anuj, would you like to? Dr. Anuj Bhatnagar? Dr. Amitesh, can you take the questions till then?
Yes, ma'am, sure. There are a few questions related to this case in the chat box. I will take them one by one. First, there is a question by Dr. Jayakishan sir that which one to prefer regarding this case, that EBUS versus mediastinoscopy, which one to do in this case, as she was a female patient and there may be a possibility of scarring if mediastinoscopy is done. Dr. Sanjeev, can you answer to that, please?
Yeah, so I think in this particular patient, the issue was that cervical nodes were present. In fact, we took a cervical node biopsy, which came negative for everything, and it was giving us a alternate diagnosis of Kikuchi's and all that. So the idea of mediastinoscopy versus EBUS is that EBUS, obviously, like Dr. Jayakishan rightly pointed out, is a less invasive procedure and easier to do for the particular patient. But mediastinoscopy is also a safe procedure. The idea of mediastinoscopy is that you get an entire node. So this is a case of diagnostic dilemma where your sputum is negative, sputum culture is negative for TB, your lymph node from the cervical biopsy is actually negative. So when you take a tissue, I mean, when you take a node now, you want a chunk of the node which can cover all particular diagnoses, including lymphoma, including TB, including Kikuchi. So it was judged by the doctors there that mediastinoscopy would give a better result. I think Dr. Arjun is there in the chat. I mean, if he wants to add to that, I think I have covered for them. They had worked up the patient. So that is how they did it. I assume, Arjun, you want to add something? You can add, or Dr. Singla, I think Rupak Singla is also wanting to add.
Dr. Anuj also has joined now, I think. Dr. Anuj, are you there? I think there's some issue with the technical issue. So
I am there, Dr. Nika.
Okay, Dr. Anuj.
Dr. Nita, can I add something in between before that?
Sure, sir. Sure, sir.
Yeah, thank you. Because I am a thoracic surgeon, so I think this case shows the continued importance of mediastinoscopy to be available. Because as a thoracic surgeon, I feel because we are doing mediastinoscopy in lesser and lesser numbers, the expertise to do this will also not be available. While sometimes in this case demonstrates you want an adequate tissue, a complete node for a complete thorough diagnosis. So mediastinoscopy definitely affords a better situation, and I have seen cases where mediastinoscopy is actually therapeutic also, because sometimes they develop abscesses around these nodes, and those abscesses also get drained at the same time, completely drained and sucked out, and then the healing takes place much better. So what is important as us is to maintain the expertise for mediastinoscopy to be continuously available, because that is going into, with the availability of EBUS, that expertise is becoming rarer to find. Thank you. Over.
Okay, to add to what Sir has said, yes, this case has been worked up wonderfully. There are just one or two things which are learning aspects from this case. Please remember that any case of a lymph node TB, simply a suspected lymph node TB or a proven lymph node TB, quite a number of us in the field, we actually start the treatment and we start the treatment as a short course treatment. Kindly remember that lymph nodes somewhere, please rule out lymph nodes everywhere. It has to be ruled out everywhere. Kindly look for the lymph nodes in other areas which are especially non-contiguous, because in these patients, you might need to require a longer regimen or accessible. Secondly, this has been sampled and an adequate sample has been obtained, and probably a culture also has been done. I saw the date of the report. It was November 2020, where a report of the LPA was there, which showed that high dose moxifloxacin cannot be given. And at that particular point of time, that intervention was prompt and the treatment regimen was modified, though the guidelines at that time did not permit the use of Delaminate, but by that time the National Committee had already approved the minutes where Delaminate was the first option for replacement, and Delaminate was available, and the patient opted. In fact, injectable could have been given, but two factors weighed against it. One was the late duration of the IP. Yes, in the first 6 months, you can actually start an injectable if Delaminate is not there, but it was already ending 5 months, 6 months in fact. So it was decided, and the patient refused for injectables. So at that time, it was decided to basically not to give the injections. And because of her underlying liver condition, that is the reason why a chance was taken not to give ethionomide and pyrazinamide, because quite a number of us have seen reactions to ethionomide, hepatotoxicity to ethionomide is very common in every patient who is receiving it. And in this case, since the background resistance to pyrazinamide also in India is very high, it's around 28 to 29%. So that is the reason why all these factors weighed in while deciding that it's best and safe to continue bedaquiline. One of the other points that we all need to learn from such a case. Please remember, let's go back. How did the case start? She started as a case who was COVID positive. Even though she was asymptomatic, she developed fever after 2 weeks. And after that, she was started on long-term steroids for at least 2 weeks. Now, this is something which everybody of us must be observing. An unexplained fever or unexplained symptoms. Now, this has recently been added, and this is a very welcome addition. In a COVID patient, you have to rule out TB as a comorbid condition. This thing we have all observed in quite a number of our post-COVID patients, extensive TB happening. And in this case, this is one of the examples of such cases. And Dr. Nair, I'd like to ask one thing as to in what particular condition, and what is the condition of the patient as of now?
Thank you, sir. Thank you for the comments and the support for the patient. So like I said, the patient has improved a lot, totally asymptomatic, has a weight gain of 10 kilo, and she's doing extremely well. She's back to her studies and all, and she's doing extremely well. And in fact, she was helping us with this particular presentation. So, you know, that we actually salute her for her bravery and efforts for that. So that is there. And in fact, Dr. Arjun was muted and he could not unmute himself. So he had actually passed on the message that in this particular patient, they did consider EBUS versus mediastinoscopy. So it was also discussed because the patient herself was a doctor. So they discussed with the patient also. So one of the differential diagnoses was lymphoma. So like Dr. Devan actually pointed out, the need for a complete tissue was felt, and after the discussion, the patient herself opted for a mediastinoscopy. And like sir rightly pointed out, you know, having capacity for mediastinoscopy itself is a big thing. We even in the government sector often struggle to get a mediastinoscopy done. So in fact, I would congratulate the KIMS team for having excellently worked on this particular patient, Dr. Arjun and his team. I think Dr. Singla wants to add to this. Yes, sir.
Yeah, thank you so much, Dr. Shikha and Dr. Nair for this excellent presentation and discussion, and Dr. Anuj also for his very wisely comments. You see, I would like to go one step before also. You see, initially she was diagnosed as Kikuchu disease. If you see the Kikuchu disease, first reported in Japan, classical presentation is young female presenting with fever, lymph node, and even headache could be a prominent symptom. She had all of them. Now a biopsy is done in a good center and reported as possibility of Kikuchi disease. You see, now in a country with a high prevalence for tuberculosis, so anybody will be tempted to accept this diagnosis because of the classical presentation and go ahead with this, wherein it is a self-limiting disease. Some patient may need steroid, something like that. One may like to wait and watch. But I must thank the team that they did not stop there. They questioned the diagnosis of Kikuchi disease and they went ahead. Now the next question which is being discussed is whether metastanoscopy or what? Biopsy. And secondly, you know, the diagnosis of Kikuchi is done by biopsy. And this was a biopsy wherein the pathologist has mentioned possibility of Kikuchi disease. So she was fulfilling all the criteria for a Kikuchi disease, except that it is a very, very uncommon disease. And in a high prevalence country, especially post-COVID, as Dr. Anuj rightly pointed out, one should consider possibility of TB, and being a medical student, again, being exposed to TB patients. So that was rightly considered. Although for argument's sake, one may say she also had axillary lymph node, axillary biopsy could have been done. But definitely EBUS versus metastanoscopy and biopsy, because once you have a diagnosis of Kikuchi disease in mind or even lymphomas, these things in mind, I think FNAC becomes less acceptable to the doctors as well as patient also being a doctor. So the idea of taking the entire lymph node, idea of going ahead with a biopsy and then subjecting it to everything, I think that was a wise decision which was taken by the team treating this patient, and that was done. Now coming to the next scenario, that is regarding this case as pre-XDR TB with even high dose moxifloxacin cannot be used. So replacement, yes, at the end of 5 months, linezolid is not being tolerated. So I think it was also a wise decision not to add injectable at that time. The choice was between adding pyrazinamide and ethionamide versus in the continuation phase going ahead with the bedaquiline as a long term. 2-3 issues. You see, PZA DST was not available. Although the culture, I do not know whether the culture of the lymph node was done or not, and if the culture was done, DST should have been available. But here I would like to tell the DDG is also there. That still I find, although we have noise about this for last so many years, we find in the field, the pyrazinamide DST is not being done frequently, even in the IRLs. Then this is a fact in the field which needs to be corrected. That as a routine, we should have PZA DST available in the field if the culture is done. So please, my humble request with folded hands that need, because PZA is a drug in the replacement sequence. After delaminate, then we go for this injectable and then pyrazinamide. So being such a higher up in the replacement sequence, and in absence of DST for PZA being susceptible, it is not to be considered because the pyrazinamide resistance among an NBR is to the tune of 28-30%. So that means that we should have PZA DST available in the field to choose the drug from the replacement sequence. So the next, plus also she had mild elevation of the liver functions. So keeping these two things in mind, that elevated LFTs with possibility of making them normal by the use of both the drugs, pyrazinamide and ethionamide, which both of them are hepatotoxic. The decision of continue with bedaquiline, I think that was correct. But for everyone, because here we have all the DTOs also joined, the indication of prolonged use of bedaquiline is when you do not have more than 2 of the first five drugs of group A and B, and you do not have enough group C drugs to make a good regimen either in the intensive phase or in the continuation phase. We should not think of, like in the continuation phase itself, of course, we should not think of continuing the bedaquiline for long term. That is the current guideline, which may change depending on the need. But as of today, we should think of bedaquiline extension only when you do not have more than 2 from these first 5 drugs, and you do not have enough group C drugs. So these are my comments. Thank you for giving me this time. Thank you.
Nita, may I come?
Sure, sir.
At the very outset, I must wish you all very happy New Year. I think the case was very thoroughly worked up, and I must compliment the whole team, including Sanjeev Nair and everybody. My 1 or 2 questions, and ultimately, you know, clinician, what I believe that patient has improved, has gained 10 kg of weight. Now she is working. So everything, if everything went well, it is 100% that was whatever she was there, she was there. My one question is, at this stage, we have, you know, this case we started from diagnostic dilemma with between Coach's disease, tuberculosis, no tuberculosis. Then we finally went to diagnose her as a pre-XDR tuberculosis by doing a mediastinoscopy. I think that decision was very valid because as one of the diagnoses was lymphoma in this particular young lady. So that decision, I also agree that that was very good because we could get a whole lymph node. Now, my one question to all of you is, although that if we could diagnose up to pre-XDR TB, what, forget that suppose this patient may not have responded at the end of treatment. So what was the decision, how we have excluded XDR TB in this particular lady as per current definition of XDR TB? Because we had available lymph node, I think culture was done. If the culture would have been positive, then sensitivity was also possible. But I would like to know from Dr. Rupak and other people sitting here, is the bedaquiline, and because as per the new definition of XDR TB, apart from the fluoroquinolone, which was there, the drug resistance to one of the drug like bedaquiline or linezolid. So, Rupak, just I wanted my own knowledge, whether the facility is available in the country for doing the DST for these 2 drugs?
Yes, sir. Thank you first of all for your question. In very few centers like NIRT Chennai, our institute, that is NITRD, it is for bedaquiline as well as delamanid, the facility is available. And the Central TB division is gradually expanding it to the other IRLs and NRLs. But definitely it will take time. But in these cases, once it is vital, like even in this case, maybe, then one of these institutes can be contacted, the sample can be easily sent, and the DST can be made available. So that should be resolved.
Yes, Rupak, I agree with you. That was my point I wanted to make. Since I know Kerala, all the Kerala people, they are very good, but ideally when lymph node was taken out, the biopsy sample should have been sent for culture and DST even for the bedaquiline and linezolid. Because now here's a perfect science, what we are doing. But I am happy that ultimately patient has responded, patient has gained weight, now she has joined duty. So it means diagnosis was very correct. She was up to pre-XDR. It was not an XDR TB. Sanjeev Nair.
Sir, I agree with you. I mean, in the ideal case scenario, being a doctor, I would have loved to do the entire panel. But I think we are doing that currently when a patient is not responding. So when a patient is not responding, like you said, at that point of time, we do send a additional sample to the NRL. For us, it is NIRT Chennai, where we send a sample for a bedaquiline sensitivity.
No,
later.
Sanjeev, what I was saying, that not at the late stage, at the very beginning stage, when you've got a lymph node available, and seeing that she has already gone up to the pre-XDR TB, then why it can't be an XDR TB? So exclude that, I think. The sample should have sent at that time to a higher, as Rupak was saying, that either in his center or in some other center, where then you should have made very clear, ourselves clear, yes, it is pre-XDR, it is not XDR. But ultimately, you know, as a clinician, you know, I know that patient has responded, so we are more than satisfied. But that was my point.
Yeah, here I would like to add one thing, that in routine we should not be sending all the cultures for bedaquiline and delamanid just to rule out XDR.
Definitely
but in
not.
this case, since the decision was being taken to extend the use of bedaquiline, so especially in this case, it could have been thought of.
Yes,
but
that was
in
my
routine
point, Rupak.
Without XDR. Yes, sir. There you have a point, sir. Thank you, sir.
Thank you, sir. Thanks a lot. And since we are crossing our time, Dr. Rishi, I'm not able to take your comments. Maybe you can put them on the chat. I'm sorry. Today, like Dr. Sanjeev was saying that, you know, these difficult cases keep coming. So today we have many platforms to discuss such cases. Earlier, we didn't have this expertise and there were very few people who were, you know, able to take decision for such cases. But today we are able, the CTD has been able to create several platforms. Like we have nodal DRTB centers where there is a expertise, you have state PMDT committees, then you have state difficult to treat TB clinics and national difficult to treat TB clinics. You can send your difficult cases through nodal DRTB centers to either to your state difficult to treat TB clinic or to our national difficult to treat TB clinic. We have also made a WhatsApp group where you can get instant, you know, if experts are available, they are able to give you some expertise there also. We are sending you WhatsApp link. If you want to be in that group, you can join us in that group. So with this, I would like to close today's session. I would like to thank the states who have joined. Today, we are joined by more than 15 state TB officers. A very big thanks to you. We have STOs from Kashmir, Punjab, then we have from Jharkhand, Uttar Pradesh, Himachal Pradesh, Andhra Pradesh, Rajasthan, Maharashtra, Delhi. We have a big team which has joined us, Gujarat, Meghalaya, Manipur, Mizoram, Nagaland, and then Bihar, West Bengal, Jharkhand. So thank you all the STOs and the team of DTOs who have joined. I would like to inform our DDG sir that, sir, today we have representation of more than 550 spokes, and we had everybody right from Kashmir to Tamil Nadu. There are DTOs from all the states. Then we have from Rajasthan and Gujarat, and then everybody in Northeast, Meghalaya, Mizoram. So I think this is one platform where we are able to discuss the difficult cases, come to a consensus, and the whole India can, you know, follow. All the states can follow those guidelines. So thanks for giving us this opportunity to create this forum for such discussions. Thank you so much, sir, and thank you all the experts. Thank you all the participants and our, you know, strengths, Dr. Rajendra Prasad, sir, Dr. Jaikishan, sir, Dr. Behra, sir, all the senior faculty who have been constant support to us. Thank you so much. Thank you, everybody. And we have floated the poll for your feedback. Kindly answer these poll questions. They help us to improve our next session. Thank you so much. And now I request Dr. Ashok Bharadwaj, sir, to give his closing remarks.
So thank you, Nita. Thank you, Nita. So I take this opportunity to wish a happy new year to all those 555 participants who made it a point to join this important discussion today. So starting from the clinical management protocol, which was presented by Dr. Sandeep Chauhan on behalf of Dr. Ravinder Kumar. So this is a wonderful development by the CTD, and this management protocol, this will be for me, this will be very good for community health officers who are working in health and wellness centers, because it will give them the ready reckoner how to take one patient who is presumptive tuberculosis to the logical conclusion. So thank you, Dr. Sandeep Chauhan. Thank you, Dr. Ravinder. And then I congratulate the doctor who presented the case, Dr. Shikha, wonderfully presented by her, and then Dr. Sanjeev Nair. So Dr. Sanjeev, I am thankful to you because I, as non-clinical person, was able to understand how you can substitute one drug with other. So thank you very much. So I never knew in such minute detail how you substitute one drug when it's a very difficult situation. So thank you, Sanjeev. So I always heard you at different platform, and I was always impressed by your justification and your knowledge. So thank you, Dr. Rupak Singla, always advising, always giving solutions to the most difficult cases. So then Dr. Neeta Singla, for giving me opportunity for time and again. So thankful to you couple, Dr. Rajinder Prasad and Dr. Diwan, whose institution is taking this lead for enlightening the whole fraternity of TB champions. I will say that we are all TB champions. We are all working for that patient of tuberculosis, and our aim is that only. So then at the end, I will thank our Deputy Director General, Dr. Tuberculosis, Dr. R.K. Joshi, who has taken the lead in all directions. So he is working on many fields, and hopefully under his leadership, under his guidelines, we will be reaching to ending TB from the country by 2025. So thank you very much. Thank you all.
Thank you, sir. Thank you so much. Thank you, DDG sir, Dr. Diwan sir, Dr. Rajendra Prasad sir, Dr. Sanjeev Nair, Dr. Anuj Bhatnagar, Dr. Vashish, Dr. Ashwini Khanna, and all the state TB officers and everybody. Thank you so much.